Thank you so much for inviting me back. I'm thrilled to be here. I am a medical anthropologist, as Scott just explained, with training in international public health. But most of my focus has been on infectious disease, so as opposed to chronic disease. But someone who I admire and adore very much asked me to participate in this, and that's Kay Reichlen, and so I couldn't refuse. And in the process, I've learned a lot about social science research in cancer. So I'll share with you a little bit of what I've learned, but then the latter half, oh, thank you. Is it this one? Okay. The latter half of my talk will be kind of a public service announcement. And it'll be about medical information, how we gain it on the internet, and how to navigate that. So I'm hoping that this will be useful to you because it's important with regards to cancer. So this is what I intend to cover in this presentation. I'll begin with basic facts, including what any good social scientist would begin with, and that is, of course, the origins of the word and the meaning of cancer itself. I'll introduce some of the vitally important social science themes that matter in the study of cancer, and thereafter I'll address some of the practical importance, or something of practical importance, as I just noted, and that is something relevant to all of us. And let me explain what I mean here by professional and popular sector. So medical anthropologists differentiate between popular folk and professional sectors of medicine and healing, recognizing that considerable amount of medical diagnosis and treatment and care take place outside of the clinic, outside of hospital settings where health professionals operate. As you know, today, cancer patients and the rest of us have access to truly enormous amounts of information, unprecedented amounts of information about their illness and about treatments. How we all navigate the enormous abundance of information matters, and we'll talk about that. So how do we find quality and reliable information in the saturated internet traffic? So in the latter part of this presentation, I'll address these questions straight on. So anyone studying cancer would begin with, be it a scientist, a clinician, a scholar, a writer, they'd begin with, I would hope, something about basics of the notion of cancer. So raise your hand if you know the answer to this. Who was the first person to use the term cancer? Really? I didn't know either, so. The word cancer was first used by Greek physician Hippocrates around 400 BC. Hippocrates is said to have named the masses of cancerous cells karkinos in Greek, and that's the Greek word for crab, because for him, a malignant tumor and the swollen blood vessels around it reminded him of a crab dug in the sand with its legs spreading in a circle. Interestingly, the term oncology, the field of medicine dealing with cancer, is also derived from ancient Greece. Onkos was the Greek term for a mass or a load, or more commonly a burden. So by the year 200 AD, the Greek physician Galen had applied this term to medicine. Which species are vulnerable to cancer? Of all the species? Yes. Invasive tumors occur in all complex species. How long has cancer been plaguing the human beings? Very much too long, yeah. Okay, so this one's interesting. Though cancer has often been referred to as a disease of development or thought of as an unfortunate product of modernity, we now know that cancers and tumors have occurred since the dawn of our species and before then. So among our ancient relatives, Homo sapiens, the Australopithecines dating back 2 million years, we found cancers. And this actually is really new information. This past summer in South Africa, scientists identified the first known tumor on the spine of a young child that was dated 2 million years. So clearly cancer is not at all new, nor a product of modernity. So some basic facts. Cancer is today, and this is going to dovetail nicely with Vivian's talk, cancer is today the second leading cause of death in the world. The leading cause is heart disease and stroke. In 2015, cancer was responsible for 8.8 million deaths, and today nearly 1 in 6 deaths in the world are due to cancer. According to the President's Cancer Panel, some 41% of Americans will be diagnosed with cancer during their lifetime, and about 21% will die of cancer. These numbers and the magnitude of cancer in our world today are difficult to digest for those of us who recall the confident and hopeful rhetoric surrounding the signing of President Nixon's 1971 National Cancer Act, which came to be referred to as, you got it, the War on Cancer. With the infusion of resources granted by the National Cancer Act, many medical scientists and others at that time somewhat immodestly projected that we would eradicate cancer in 10 years' time, 1982. But here we are today, almost 50 years after the war on cancer was declared, with the United States spending last year more than $5 billion for cancer research and approximately $125 billion for cancer care. Most disturbingly, the World Health Organization projects that the number of new cancer cases is expected to rise about 70% worldwide in the next 2 decades. Clearly, cancer has not been eradicated. So now, having painted this devastating cancer scenario, I aim to make a case, that's my case, that our efforts must indeed extend beyond the clinic and the lab, as the title of my presentation suggests. Cancer research that takes place on patients in clinics and among bench scientists within laboratories is, of course, vitally important. But this research ultimately is insufficient to address and resolve many of the most confounding challenges around cancer. This is because the many causes of cancer and efforts to prevent it, the diagnosis of cancer and the myriad and ever-changing treatments to manage it, the pain, suffering, and psychosocial challenges associated with cancer, and all of the financial, insurance-related, legal, policy, and ethical matters associated with cancer operate within complex webs of social meaning and political and economic constraints. In other words, our collective efforts to prevent, research, treat, control cancer cannot be divorced from the social context in which these efforts are embedded. The most important lesson learned from the devastation wrought by the global AIDS pandemic is that the most sophisticated and highly effective treatments cannot alone control the spread of that disease and others. This is a little bit of a retreat into my world as an infectious disease specialist, but it's relevant here. In 2006, more than 10 years after the antiretroviral therapies dramatically slowed the progression of HIV in individuals, thus keeping people alive, people with AIDS alive, the medical world wondered collectively at the 16th International AIDS Conference why the disease was still spreading so rapidly in so many areas of the world. We finally had effective drugs, guaranteed to slow the virus, the spread of the virus. Why then was HIV still spreading? In response to this question that permeated the conference, then director of the United Nations AIDS program, Peter Pio, explained boldly to the thousands of people who had gathered for the conference. And this is what he said: an AIDS response that is not as embedded in advancing social justice as in advancing science is doomed to failure. For one, the prices of the drugs were prohibitively expensive for the vast majority of people sick with HIV. The disease would therefore continue to spread rapidly if the world did not figure out how to get the antiretrovirals to those who needed it. Of course, HIV, a communicable infectious disease, is different from cancer, but the point I think we need to internalize is relevant here. We need to address neglected areas of behavioral and social scientific research surrounding all aspects of cancer prevention, diagnosis, treatment, management, financing, policy formation, and more. Consider these questions, and I think Vivian addressed some of these very, very nicely. Where and in what populations does cancer take its heaviest toll, and why? Which is more prioritized and financed, cancer prevention or cancer treatment? Why? When treatments do become available, who gets treated and who does not? Why? What kinds of cancer are most privileged for research and what cancers are neglected? How are such decisions made, and by whom? To what extent are resources allocated to address the psychosocial effects of cancer among patients and among their caretakers? What corporate and other interests promote or thwart research on cancer prevention? These are just a few of the questions social scientists are endeavoring to answer. Many are squarely focused on the medical ethics and the distributive justice issues in particular. Again, I think Vivian addressed this quite nicely, comparing resource-poor areas of the world to wealthier areas of the world. Another area of study among social scientists is who studies cancer and what do they do? And importantly, do they collaborate? This became an important question to me and one of my colleagues, who I think many of you know, Barbara Stebbins-Boas, the biology professor at Willamette. We collaborated on a summer research project where our students were up and down the Willamette Valley trying to understand basically environmental health issues. We learned in the course of that research that one of the problems here in Oregon seems to be that at the government level, in the halls of power, we may be seeing, this is how it was explained to us. We have a whole wing with committees and experts in the environment, studying the environment and developing policies about the environment on one hand, and then over here we have committees and legislators focused entirely on health and public health over here. But we don't have the convergence of these. And this ends up being a problem. Some states do. Oregon as yet does not, but it might be one of the reasons why some of the collaboration among research is not happening so much. So let's look at who does work in cancer. As you know, molecular bioscientists study cell types, genetic mutations, environmental factors associated with cancer. And there are a wide array of clinicians involved in cancer, diagnosing and treating cancers. Oncologists, as you know, manage the care and treatment of patients once they are diagnosed with cancer. And there are multiple kinds of oncologists. There are medical oncologists who treat cancer using chemotherapy, et cetera. There are surgical oncologists, radiation oncologists. And there are other kinds of oncologists as well, gynecological oncologists, pediatric oncologists, hematologist oncologists. And of course, there are all the nurse oncologists, as well as the entire array of allied health care professionals. Don't try to read this. It's just an image to show you. This is what this collection of tables, graphs, maps, this is to show you the fruits of epidemiological research, which Vivian also demonstrated really nicely. Cancer epidemiologists map the distribution and patterning of cancer in local areas and globally. They study the determinants of the likelihood of cancer development. Cancer epidemiology can be used to identify events that increase or decrease cancer incidence. The epidemiology of cancer studies factors affecting cancer as a way to infer possible trends and causes. And they use methods to identify and develop improved treatments. Many epidemiologists also work or are themselves social scientists. Like myself, I'm trained in both epidemiology and in medical anthropology, which dovetails nicely together when we do research. But what do social scientists do? That's what I want to speak with you a bit about here. These are the few areas, very few because there are many, but these are some of the areas of inquiry in the social science of cancer. So people discuss the word and its meaning, and we'll talk about that in a minute. They discuss medical metaphors, carcinogenic environments, ethics in cancer research treatment, and political economic factors regarding cancer in the world today. So once we understand the origins of the word cancer, which we all know now was Hippocrates who came up with that, we might go on to discuss the full force and reach of this term, of this noun, and what it has, how it affects our collective imagination. In a brilliant 2013 book entitled *Malignant: How Cancer Becomes Us*, a medical anthropologist, S.L. Jain from Stanford University, writes this. I'm going to read you a paragraph, and I'm going to read it very slowly because it's poignant, and it gets to a lot of what anthropologists and other social scientists research. Cancer, this is what she wrote, "Cancer is at one moment a paper trail, and at another an identity. At one place, a statistic, and another place, a bankruptcy. Here, a scientific quandary. There, a transcendent image of a cell. One person's losses offer another chance to leave a mark on humanity. A body image taken offers another to be found. The project of making cancer, as plural as it is singular, as vast as it is microscopic, as diffuse as it is discrepant, as it is descriptive, resonates under one word. The single noun, cancer, consolidates this collective achievement. So let's talk about metaphors. What is a metaphor? This is something that social scientists have focused a lot of attention on. So it's something used or regarded as being used to represent something else, an emblem, a symbol, such as time is money, or importantly, the war on cancer. In the US, images of war have long served as key organizing categories for cancer. We battle cancers. We become survivors and warriors. Here, for example, is a paragraph taken from a 2014 article published in The Lancet, the British medical journal described by some as one of the most prestigious medical journals in the world. This is written by a scholar in direct response to the pessimism that he had encountered at the World Oncology Forum in 2012 regarding the future of cancer in the world. This is what he said, quote, "We need a three-dimensional cancer battle space plan that can be envisaged to include disruption of several capabilities of the enemy, neutralization of specialized divisions of the enemy's armed forces, and integration of the distinctive geographies of organ battlefields." Social scientists have long examined how such war metaphors are received and interpreted by cancer patients who may be blamed when they do not battle hard enough to fight their cancer within, as if they have in some way some control over that process. Other scholars have noted the ironies of the metaphors, that the real weapons of war, for example, nitrogen mustered in World War II, atomic radiation in nitrogen mustered in World War I and atomic radiation in World War II were not only causes of cancer, but also later some of the first treatments of cancer. In this way, cancer is very much a part of the military complex. Others suggest that while war metaphors against cancer have pragmatic uses, to rally resources and imaginations, for example, they sometimes turn out to be illusions, which can bring forth a false sense of control. In 1978, American author, essayist, filmmaker, and political activist Susan Sontag wrote an influential book called Illness as Metaphor. She had cancer herself when she was writing it. The book was described by Newsweek as one of the most liberating books of its time. Recall the image and ideas around cancer in the 1970s. It's very different from today here in the United States. A cancer patient herself, when she was writing this book, Sontag shows how the metaphors and myths surrounding certain illnesses, especially cancer, add greatly to the suffering of patients and often inhibit them from seeking proper treatment. She wrote of the silences, the shame, the fear surrounding the disease, and endeavored to demystify the fantasies surrounding it. In the work, she shows cancer for what it is, a disease. Cancer, she argued, is not a curse, not a punishment, and certainly not an embarrassment. Almost a decade later, with the outbreak of a new, also highly stigmatized disease, replete with mystifications and punitive metaphors, Sontag wrote a sequel to Illness as Metaphor. This one extended the argument of the earlier book to the AIDS pandemic. Other efforts by social scientists examine, for example, how political economic dogmas such as neoliberalism can lead to highly inequitous cancer treatment and care, and problematize victim blaming in certain populations. There's a lot of research in pockets of America where people are not getting treated, not even getting diagnosed, and the social scientists are trying to analyze why and how that is. Other social scientists focus on the dynamics of race and health disparities in research and what have been described as obscured values and biases in national level research projects. Others look at the divergent meanings given to numbers, cancer rate statistics around drug efficacy, and how some women in particular come to be embodied as individual pathology when their cervical cancer is linked solely to their women's individual behaviors, as opposed to their life conditions. Social scientists are as likely to focus on industries associated with cancer because, as one such scholar notes, quote, "In focusing on the behaviors of smokers, we miss the impact the production and distribution of cigarettes on the global scene and the global increase in cancer mortality brings." Relatedly, social scientists are very much attentive to the fact that so much emphasis continues to be placed on clinical medicine and finding magic bullets and cures, where strategies to prevent cancer remain, to this day, a very much neglected area of inquiry. As one scholar explains, quote, "Only by acknowledging the limitations of the medical model and returning our attention to broad-scale factors, such as those affecting the quality of air, water, household environments, and the global climate, are we likely to make real progress in reducing chronic diseases, such as cancer." Many social scientists advocate in their work for adoption of principles, such as, for example, the precautionary principle, which acknowledges the limitations of what can be known, but pushes us to take action to reduce potentially large-scale irrevocable harms, even when knowledge of that harm remains incomplete. Lastly, a lot of social science research examines the democratization of science and the need to invite citizen participation regarding public health and efforts to bring harmful exposures to the fore. Have you heard the concept citizenry science? Science among the citizenry? There's a lot of effort going on right here in Oregon to have just the public take work with DEQ, for example, Department of Environmental Quality, to help alert them when there's issues in their environment, in their homes, in their neighborhoods and such. So getting citizens more involved in this work. Social scientists are also concerned with epistemology. And now I want to sort of shift gear here. Think about this. How do you know what you know about a particular kind of cancer? Consider that for a moment. How do you know what you know about a particular kind of cancer? Where did you learn this information? How do you know that what you know is accurate? Social scientists are keenly interested in such questions of epistemology. So what that means is simply a branch of philosophy that investigates the origin, nature, methods, and limits of human knowledge. Understood more broadly, epistemology is about issues having to do with the creation and dissemination of knowledge in particular areas of inquiry. So how do oncologists and other cancer care providers know what they know about, importantly, cancers? And importantly, how do they keep up with the latest medical information? How do they do this? I know that we have a lot of medical providers in the audience. We can make a long list. Most hospitals have libraries, medical libraries. Clinicians attend conferences and workshops to keep abreast of the latest literature and to fulfill their CME, their continuing medical education requirements. They attend grand rounds at the hospital, have informal conversations and meetings with colleagues, et cetera, et cetera. They also read medical journals. But this is becoming increasingly challenging due to the high volume of research and publication. According to the British Medical Journal, there are now more than 25,400 medical journals, and their number increases by 3.5% every year. In a single year, these journals publish more than 1.5 million articles. PubMed now cites more than 20 million papers. This proliferation led the authors of this British Medical Journal to wonder, is this why we're getting so micro-specialized in medicine? How could you be a specialist with that volume of information, trying to understand too much? So people are becoming more and more and more focused and micro-specialized in their practice. Of course, medical professionals are not the only ones overwhelmed and inundated with this information. So are the rest of us, the popular sector. By the way, do you know the origins of the word overwhelmed? This comes from the early 14th century. It means to turn upside down or to submerge completely, as in a boat in water. I think it's apt. So indicate, please, by raising your hand if you have ever searched the internet for answers to health questions. Okay, I didn't. Everybody, right, of course. So many of us have, well, actually, raise your hand if you felt confident in what you gathered in your internet search. Okay. Many of us have pretty mixed emotions and mixed success consulting the internet for health information. We may be grateful for the ease of access of this information, but frustrated waiting through the vast amount of information available on any given topic. So how do you find reliable information? Currently, the internet is replete with information for people facing cancer. You can find basic facts about specific kinds of cancer, how to locate clinical trials, find support groups online. You can also learn all about different health providers, clinics, research studies, treatment guidelines, drugs, complementary and alternative medicines, etc. The information comes from health organizations, universities, interest groups, the general public, and scam artists. Anyone can post any kind of information online. But as you know, a lot of what passes as cancer information and expertise on the internet is made up of opinion, salesmanship, and testimonials that are not grounded in actual research. Thankfully, the United States Federal Trade Commission, along with the National Library of Medicine, the National Institutes of Health, the American Heart Association, others, are aware of the vast number of ways that presumed medical information sites may be delivering fraudulent and downright dangerous information. These and other organizations have been trying to educate the public by developing videos and tutorials for how to become discerning consumers of internet-based medical information. Of course, they all begin and conclude with statements that urge the public to first consult your physician. I want to go into some of the detail here. If you were walking down the street and you saw a sign in front of a small, kind of rundown store that claimed it was the largest supplier of medical devices in the United States, you might be a little dubious, right? But if you saw a professional-looking site on the internet that made the very same claim, you would have more difficulty deciding if it was real. In contrast to actual facilities and real signs, advertising on the internet is inexpensive, it offers an expansive reach, and, importantly, the authors can remain relatively anonymous. So we need to be vigilant in our consumption of internet information. We need to arm ourselves with intellectual self-defense against being misled or duped. Though we cannot always be sure that the information we find that we believe to be accurate on the internet is in fact accurate, there are tools and questions we can employ to help find the best, most reliable information. Here's a sample of the kinds of questions these organizations urge us to pose as we search the web for medical information. Is this site paid for by an individual or an organization? What type of organization is it? Is it a business? Is it a government organization? Is it a university? Any honest health-related site should make this easy for you to find. So one of the things we can do is click on About Us. If they don't have it, that's already a sign that there's a problem. But most legitimate sites will have either at the very top of the website or at the very bottom a little About Us. You can click on there to begin. You can also get an idea of who runs the site by looking at the letters at the end of the URL address, called the top level domain name. So for Willamette University, it's willamette.edu. That indicates it's an institution of learning. A college or university, and educational. There's also .org, as you know, .com, as you know, .gov for government. And then there's .biz, which usually means the site is run by a commercial for-profit source. So all of those together could be informative. Knowing whether the information came from a business, a university, a non-for-profit group can be useful because it could give you some insight into why the individual or organization is providing that information. There are other domain names, but these are among the oldest, the edu, org, gov, .com, and .biz. Okay, those are the most common. In the United States, we don't do this, but other countries actually have a 2-letter code that comes after the end of the basic URL. For example, India uses IN, Australia uses AU. You might notice information from the British government agency that includes .gov for gov.uk. This is important because we need to know where information comes from, because while the general information may be good, sometimes the treatment information and availability of the statistics and whatnot in other countries might differ considerably from what we have in the United States of America. In the US, the most reliable sources of health information tend to be government agencies, hospital, universities, and other major health and health advocacy organizations. These groups use information that is reviewed by noted experts and is typically updated. Who funds the site should also be easy to figure out. It is important because it can affect what is presented on the site and how it is presented. If the source is a commercial business, and sometimes this is so difficult to figure out because the commercial businesses are getting more and more clever, replicating precisely what the legitimate medical sites are doing. But if it's a commercial business, such as an advertiser or a provider of a service or product, there may be some bias or prejudice in the information. Government sites, universities, public health groups generally seek only to educate the reader. But even on a nonprofit website, if the site is full of advertisements or is supported or funded by an outside company, it is important to ask yourself whether the information there may be biased in some way. So what is the purpose or mission of the website? That's important to know because it usually is related to who runs the site. In most cases, this information can be found with clicking on About This Site or About Us, which is usually, again, at the very top or the very bottom. I encourage you to use these and check into them. Again, websites designed to promote or sell products may be more likely to have slanted or inaccurate health information than sites designated to simply provide information. Some sites try to do both, but you should look at these carefully. Remember that if a site's main purpose is to sell products, it will only contain the information the seller wants you to know. Where does the information on the website come from? Can you tell where the information on the site originates? Is it based on medical literature and research, or is it based on opinion and personal experience? Personal stories in the form of blogs, testimonials, anecdotal reports, these may be quite compelling, but they also might not apply to you. A few people saying that they've done well on a certain treatment, for example, does not mean that most people will do well on that treatment. Can you tell what research was done to back up what's being said? More reputable websites will list references from scientific journals that support the information they give you. Does the information seem biased? Is only one single viewpoint being presented? Information should be balanced, giving the pros and cons of a subject or a treatment. If the information describes a treatment, knowing that all treatments have unwanted side effects in some people, if none are listed or discussed, that is often a warning sign. And then also, how up to date is the information? How often is the information updated? Information in the field of cancer treatment, as you know, changes almost daily. The standard of care a couple of years ago may no longer be the standard of care today. Web pages should include the date the information was posted. If information on cancer treatment is more than a few years old, more than 2 years old, most people recommend, you should look someplace else. Does the website ask for personal information? And this this is the impetus for this discussion because my parents got into this problem here. If the site collects your personal information, can you find out how this information is to be used? Can you look up cancer information without giving any personal information? Does the information you're asked to give fit the purpose stated? If the answer to these questions is no, then you might want to look elsewhere. The site's private policy, usually linked from the top or bottom of the site's homepage, should be easy to get to and clearly explained. Some websites may automatically place you on email lists or even sell your information to other organizations or companies. Know where your information may be used before giving it out, especially if you have included anything of a personal or financial nature. How is the website documented? Is there a way for users to make suggestions and comments on the website? Most websites will offer you a way to give feedback on their site. If they don't, that's also a clue that it might not be a legitimate site. If the site has a chat room, blog, or message board, is there a moderator or someone who monitors the interaction? How is the information reviewed? Who writes and who reviews it? Does the site tell you how the information is reviewed to be sure if it's correct? For example, is the information reviewed by experts in the field? And then how often is it reviewed? Who writes the material on the website? Try to identify authors, and if the authors are listed, are their credentials included? How do users interact with the site? Is there a way for users to make suggestions and comments on the website? Most sites will offer you a way to give feedback on their site. If the site has a chat room, a blog, or message board, is there a moderator? Again, does the moderator check facts or just remove offending posts? So the United States Federal Trade Commission, the FTC, offers this list. This is directly off of their website. And this is a list. This is the last thing I want to present. We'll open up for questions. But this is the list that you should consider suspicious on a website. So claims of scientific breakthroughs or miraculous cures, secret ingredients or ancient remedies that sound too good or too easy to be true. That should be, I would think, trigger some suspicion on your part. Claims that a product can be or can cure a wide range of illnesses. No one product can cure a wide range, especially within cancer. Claims that a product is available only from one source, especially if you have to pay in advance to get it. Of course, be wary of testimonials of people who claim to have had amazing results with the product. Claims of money-back guarantees. Although this might make the product seem risk-free, it is often impossible to actually get your money back. I do see some of you taking notes. I will make all of this available, and I'm making a sheet for you so you can link into some other advice and some tutorials that you can do online. Lastly, and perhaps most tellingly, be wary of websites that do not list contact information. If you cannot locate on the website the company's name, either a street address, a phone number, or other contact information, you may have accessed an illegitimate company or organization that is offshore, perhaps, and therefore away from U.S. laws and regulations. So, in conclusion, I appreciate the invitation to come here. I'm sorry I just ran through that so fast, but I think it's vitally important that we all are aware of the kinds of schemes and scams that are out there. Thank you very much. I have a question. Did this last part about the research on the internet resonate with you? Do you feel like we all need to be educated better about this? So I've been working with my students at Willamette, and what I was telling Scott and Jim earlier, they're internet savvy, they're digital natives born into this, but wow, they had no idea of any of this. Yes?
Yeah, excuse me, I'm Bob. I think one thing that you didn't mention that's kind of related here is the necessity of, no matter how much faith you have in your physician, of being your own advocate, looking out for yourself. I suspect that at looking around the room, I'm not the only person statistically that's dealt with prostate cancer. And my story, I think, is, I think I would want to share it. Last year, I had a physical when I was 70, and for the first time, I was not, screened either with a PSA or in a digital exam for prostate cancer, and I really didn't think anything about it until a month or so later, and I was talking to my doctor about another issue, and I said, by the way, I don't recall any PSA results on the blood work from my physical. And she said, well, at your age, we usually don't do that anymore. And
Ouch.
she said, and thank goodness, she said, but if you want, we can have a PSA. And I said, I want. And that led, ultimately to diagnosis and treatment and so on. But, as I said, I have a lot of faith in my doctor. I think she's up on things. But then when I was referred to the specialist, it's, well, yeah, it doesn't take into account there are different types of prostate cancer, slow growing, not so slow. And so you have to look out for yourself as well.
I think that's vitally important and very much linked to cost cutting in medicine and the profound endeavor to do that. On whose bodies will such cost cutting happen? Absolutely advocating for oneself. And I think this is what the power and the amazingness of the internet offers us. It offers us some control over the information that we're getting, but sometimes we need to be careful there too, which is, yeah, I think I made my point in that regard. Thank you for sharing that. That's very important.
Early in your talk, you mentioned that sometimes there isn't good communication between researchers and policymakers. And I wanted to point out that I know that in the state government where my husband had been working as the medical director for the Oregon Health Plan, and which is the Medicaid programs in Oregon. And he's now mostly retired, but working part-time. He's been very involved in evidence-based priority setting of use of funds for effective treatment and covering the most people possible. And I think that there's been quite a lot of work in Oregon. In fact, Oregon is quite well known for trying to use evidence-based medicine in its policies.
I think that's amazing, and I think there's a trend throughout the country for that. I was speaking specifically about linkages between people who study the health and well-being of the environment and people who work for the health and well-being of humans. That's where some of the linkages are missing. Yeah, thank you.
Well, if there's no other questions, last call for questions. Oh, all right. Well, now we get a few hands raised.
This is more of a humorous question. Should we trust Dr. Oz?
I think you should do as the gentleman up there suggested. I think you should trust yourselves and do your research, but be very well informed about what that might look like. Yeah. Yes.
Hi, this is Jan. I just have one story. My daughter was diagnosed with cervical cancer about 6 years ago.
Sorry.
At age 40, and it just scared the living bejeebers out of everybody. And so they were getting a lot of advice from people. Why are you going there? Why are you doing this? Why are they doing that? And my son-in-law was just about beside himself. And so he called a very good cancer clinic up in Portland, who, by the way, did an awesome job, and was put on the phone with an older doctor there. And he said, okay, Sean, this is what we're going to do. We've been doing this for years. We know exactly what we're going to do. And my last piece of advice for you is stay the hell off the internet.
Yeah, yeah. I've heard that again and again, actually. That's why all of these messages, they come from the medical libraries, the National Institutes for Health, the National Institutes for Health Cancer Wing, et cetera. They all say the same thing. Right up front and at the bottom, make sure you consult your medical providers first. Yeah. Yes.
My name is Don, a few years back, there was a government agency who was the agency that recommended that either you discontinue the PSA or discontinue it at a certain age. And when the committee that gave this recommendation was reviewed, there were no physicians on it, and there was no urologist on it.
Wow.
And this is also the same thing that is true about our government that recommended that you don't need mammograms until after age 50. People that deal with cancer, first of all, cancer in young women, breast cancer in young women, is an entirely different disease than breast cancer in postmenopausal women. But people who have seen patients and seen breast cancer patients can enumerate the number of young women whose lives have been saved
Birth
by
screening.
getting a mammogram under 40,
This is
or
a- this
in
is-
40, at 40.
Yeah. This is a global question.
And I do have a cynical thing. For the 25,000 medical journals, many of us live by the motto, paper does not reject ink.
Just to say about mammograms, my partner is a radiologist, and we have this conversation all the time because it's like everything else, not just in radiology, but in all the medical sciences. The information is so vast and oftentimes quite contradictory that even the specialists are having a really hard time grasping what's best. And I know that right now in radiology of mammography, there's a battle between some of the Scandinavian countries and what we do here in the United States, and what's highly recommended and what isn't. And it's really hard to grasp that. I would trust yourselves to do the research aligned with your medical providers. But also make sure that you know that the medical research you're doing is up to date, because again, it changes daily. Yeah.
Okay, this is the last question.
Well, I am impressed with what you said about your source of information, and I think, just in the last 10 years, the prostate screening, the mammography screening, the Pap screening, they're changing a lot of that. And when I asked my provider, he said he wasn't involved in all that, and a lot of it is based on cost-benefit analysis. And so maybe the cost-benefit for thousands isn't a lot, but when it's me, one, I don't care. So I ask each time, and I say, if you refuse this, I want it in my chart that I asked for a mammogram, and I want this, and the insurance pays for it. That's the other thing, though. There's some treatments that insurance won't pay for, so sometimes you're pushed by your insurance company, too, whether they'll reimburse it.
Thank you for sharing that. It goes back to your same point. Be your own medical advocate every step of the way. Yeah, good. Thank you. Thank you all very, very much.
Thank you.